Hello everyone. Am I audible? Just a second. And is my screen visible to everyone? Yes. Am I audible now? Is everything clear? So let us start today's session. Sorry for the delay. So today we are going to discuss radiation protection. But first, before going to radiation hazards and protection, let's go through what is the pattern for FRCR part 1, that is physics. So there will be 200 true or false questions. Of them are 40 stems. In each question, there will be 5 stems, which we have to choose true or false. These are the topics and the estimated number, give or take, number of questions that will be there. So there are of the 200 true or false questions, that is a 40 stems. So 40 questions will be from 4 questions will be from radiation physics, 8 from radiation hazards, what we are dealing with today. Okay. 8 from radiation hazards. That is the topic of today. Another 8 from imaging of X-rays, film screen, DR, and fluoroscopy. And CT will have 4 questions. Gamma imaging will have 6 questions. USG will have 5 questions, and MRI will have 5 questions. So coming to today's topic. So when do we have radiation hazards and protection? There will be radiation hazards only if there is ionizing radiation. So for non-ionizing radiation, we do not have any dose limits, equivalent dose, absorbed dose. Any of this is not there. It is only for ionizing radiations, that are X-rays, gamma rays, beta emitters, or electrons, beams that we get either in nuclear medicine or radiotherapy. So whenever there is ionizing radiation, then only there is, whenever the ionizing radiation interacts with the living cells, then only there will be damage. So damage will happen only if there is absorption. If there is no absorption, there is no damage. So when the X-rays and gamma rays are interacting with the living cells, there will be absorption and it will cause damage. What kind of damage will be there? After absorption, first there will be chemical changes that will happen, which will happen immediately within microseconds. And then there will be molecular damage, which will happen from some seconds to minutes. And then there will be biological damage, which can happen from in hours to decades. Okay, so this is the smallest topic that is given in FARS. So let's see how topic that we have just discussed. So it will be very interesting if you are interactive and if you guys start answering questions in the chat box. So we will start doing the true or false questions now. And I expect every one of you to start answering. Okay. So regarding radiation interactions with tissue, biological damage to tissue occurs immediately on interaction with tissue. Is it true or false? Yes. Does it happen immediately? We have just discussed that A, C, and B, absorption, chemical, then molecular, and then biological. Biological will take hours to decades to happen. So biological damage, here they're saying that it will occur immediately. So it is false. Chemical changes will happen immediately. Molecular damage to tissues occurs hours after interaction with tissues. Is it true or false? No, that is also false. Chemical changes in tissues occurs hours after interaction. That is also false. It happens immediately. The principal radiation sources for medical exposures is X-rays and gamma radiation. Yes, it is true. The principal radiation in medical exposures in diagnostic radiology, we have X-rays and gamma radiation only. Radiation interaction with tissues depends on the radiosensitivity of the tissues. So it is Yes, true. Different tissues will have different radio sensitivities. Gonads have very high radio sensitivity, whereas the skin and the other things have a less radio sensitivity than gonads. So different tissues will have different interaction with the X-rays or gamma rays. So ionizing radiation, how it will happen in depth at molecular level. After the exposure, there will be ionization. That is, free electrons will be uh, produced, and those electrons will cause free radicals, which will cause the chemical changes which will happen immediately. And then there will be molecular changes in DNA, RNA, and enzymes. These molecular changes can happen either directly by disrupting the covalent bonds or indirectly by producing free radicals. This is the most common because obviously human body is mostly made up of water. So there will be more free radicals coming, and so there is more indirect effect which is there with the tissues than the direct effect. And then after molecular changes, there will be subcellular damage to the nuclei, chromosomes, and the membranes. And at cellular level, finally, there will be either the cell death, that is a deterministic effect, or there will be cellular transformation. That means it can happen. Mutation can happen or cannot happen, or there might be some repair. And so it is called as a stochastic effect. So there is a chance that can happen or not happen. Whereas deterministic effect, it is depending on the threshold. Below the threshold, it does not. Below the threshold, if there is radiation, there will be no effect, there will be no cell death. But above the threshold, there will be cell death. Whereas for cellular transformation, that is mutation to happen, it is by chance. That is the stochastic effect. So what are free radicals? What will happen to them after interacting with the water? That is, the most of our body is of water molecules. So that is why we are talking about water here. So when radiation comes and interacts with the H2O molecule, there will be H2O plus, which will decompose immediately. And this H2O plus, it decomposes and it forms what? H plus and OH. This is the free radical. This is very reactive, highly reactive, and very powerful oxidizing agent. Within milliseconds, this is formed, and it will interact with the cell structures and all of that to cause damage. So regarding biological effects of ionizing radiation, direct damage of tissue occurs by production of free radicals. Is it true or false? No. Indirect damage is what will happen with free radicals. Direct damage is different. Indirect damage to tissue occurs by the rupture of covalent bonds. No. Direct damage ruptures the covalent bonds, whereas indirect damage will give free radicals. Cell death occurs when there is insufficient time for tissues to recover between subsequent irradiation events. Yes. So that is why even between radiations, we give a sufficient amount of time for the cell repair to happen. If there is no repair, then there is chance of cell death and permanent damage. So that is true. Free radicals produced secondary to ionization causes chemical changes in tissues. Is it true or false? Come on, start answering. Where are the regular people? They haven't joined today. Okay, so it is true. Free radicals produced secondary to ionization causes chemical changes in tissues and is independent of the type of ionizing radiation. No, depending on whether if it is X-rays or gamma rays or neutrons or alpha particles or beta emitters, it will differ. The biological effects will differ because the penetration power of each ray is different. For alpha rays, it is only a few micrometers. That is, it will only penetrate to the screen through few micrometers, and there will be immediate change here. So there will be immediate damage as thin as a strand of DNA. That is what they say. So alpha rays can damage the DNA immediately. So there will be chances for more mutation. Okay. Whereas beta rays and electrons will penetrate the skin, but they can be stopped by either perpex, as thin paper, or a thin metal lid. That is perpex. It can be stopped by perpex as well. Whereas X-rays and gamma rays and residual beam will always remain in the skin and in the absorption. There is never zero amount of X-rays that are coming out, there will always some residual beam that is there. They will pass easily through the skin and they're stopped by lead. Whereas neutrons can even pass through perpex and lead and they're stopped only by concrete. Okay, so beta particles and electrons, they are almost same as X-rays and gamma rays, and but they travel a long length, like a few millimeters more, because they are very lightweight, because these electrons and all these are very lightweight, because they don't form any attraction forces with the other atoms. They will form a tortuous path. The reason for the tortuous path is they will move a bit forward and it will cause okay. So they will give a tortuous path and they will travel even a bit more, but they're stopped by perpex and they penetrate into the skin. So that property, whichever I was talking about, that is a linear energy transfer. That is how much energy will it transfer when that, suppose these are the cells. Understanding why this is. So suppose these are the cells, and these are the X-rays or gamma rays that are going into the living tissue and they're passing through it. So how much energy will they deposit per unit length is the linear energy transfer. For alpha rays, it is so less that they will deposit their entire energy in very near to them. Whereas for X-rays and other electrons, they will deposit the energy a bit far. So high linear energy transfer, that is the energy deposited in tissue per unit path length, is more for alpha rays. That is, within closed spaces, they give all their energy, and so they have non-repairable effects. That is, the DNA, if it is exposed, they will have non-repairable effects. Whereas for low linear energy transfer particles such as electrons, X-rays, and gamma rays, they will have more length where the energy is being deposited. So for us to quantify this, we are having a term called as relative biological effectiveness. That is the ratio of absorbed doses required to induce the same biological endpoint. That is, suppose we are taking the endpoint as a mutation. So for the mutation to happen, how much will a high linear energy transfer particle will require, and how much a low linear energy transfer particle will require? If that is the measure for us. So that is how we measure. That is a measure, and how that is a reference for us to calculate how mutations will take place. So whenever we are talking about, we're talking about all of this because there is radiation, there is absorption, it is causing biological effects, and we need to quantify how much biological effects will happen. So to quantify, we need to understand how much it is absorbed also. So to understand how much it is absorbed, we have coined these terms, that is absorbed dose, equivalent dose, and effective dose. So absorbed dose is nothing but whatever the energy is deposited in that particular area. It is measured in grays. It is 1 joule per kg. It is to a specific point in the radiation field. Suppose we are talking about the whole human body, we are only talking about one point where the energy is deposited in that particular area. Okay, so it is measured in grays. What is equivalent dose? It is nothing but we are also calculating the linear energy transfer, how much energy will be deposited because of that X-ray or alpha rays or protons or neutrons. For X-ray, gamma rays, beta rays, everything, it is unity. Whereas for alpha rays, it is 20. For protons, because it is a high LET, alpha rays is high LET, protons is 5. For neutrons, it is 10 to 20. And it is, the measurement is sieverts. For X-rays, gamma rays, and beta particles, absorbed dose and equivalent dose is interchangeably used, because now we are only talking about equivalent dose, because now we are basically discussing about X-rays only. So absorbed dose and equivalent dose is interchangeably used. The unit is gray, and whenever we are talking about equivalent dose, we are talking about the radiation that the particular person will get. Okay, so what is effective dose? It depends upon the tissue weighing factors, that is the high radiosensitive organs, that is gonads, bone marrow, breast, colon, stomach, and lung. will have more tissue weighing factor, whereas moderately radiosensitive ones, the bladder, esophagus, whereas the bladder, esophagus, liver, and thyroid, all of this will have moderately radiosensitivity, whereas low radiosensitive organs, that are skin, bone, brain, and salivary glands, so these will have low tissue weighing factors. So whenever we are talking about effective dose, we're talking about equivalent dose into the tissue weighing factor. Okay. So equivalent dose is measured in sieverts. Absorbed dose is in gray, but it is numerically equal. Only the unit is being changed. So whenever we're talking about radiation protection, we're talking about equivalent dose only. For absorbed dose into tissue weighing, radiation weighing factor is the equivalent dose. Whenever we're talking about effective dose, we are talking about the variable radiosensitivities of organs and tissues, because we don't, in generally, whenever we are irradiating a part, we are having different organs that are there. Not all the organs have the same radiosensitivity. So for that particular organ, whenever we are talking how much radiation has been exposed to that organ, then we need to talk about the effective dose. I hope it's clear. So now we'll see some questions. Regarding ionizing radiation, neutrons are low LET, linear energy transfer radiation. No, they have 10 to 20. That so the radiation weighing factor is 10 or 20, so it is a high LET. The radiation weighing factor of alpha particles is 20. Yes, it is true. X-rays and beta particles have the same radiation weighing factor. Yes, it is true, it is 1. The radiation weighing factor for neutrons is unity. No, it is 20 or 10. So it is false. For X-rays, absorbed dose is equivalent to equivalent dose. Yes, because it is 1. The radiation weighing factor is 1. So it is same. Okay. The units of the following terms. Entrance surface dose is sievert. No, it is gray. I can write. Equivalent dose is sievert. It is false. Dose area product is gray per centimeter cube. It is false. Absorbed dose is gray. Joules per kg. Yes, it is true. Effective dose is sievert. Absorbed dose ke liye gray. Effective dose it is sievert. Okay. Equivalent dose is derived from absorbed dose multiplied by tissue weighing factor. No, it is multiplied by radiation weighing factor. It is measured in sieverts. Yes, it is true. Is averaged over all tissues of the body. No, effective dose is averaged over all tissues of the body. Equivalent dose is same as absorbed dose for neutrons. No, because the neutrons radiation weighing factor is 10 or 20. It is not equal. For X-rays and beta rays, yes, it is true. Takes into account sensitivity of the tissues to radiation. No, it does not take into account. Effective dose takes into account the sensitivity of tissues to radiation. Okay. So again, about absorbed dose. Relative to an organ depends on its mass. No, it is energy deposited per unit area. That's it. Absorbed dose, the definition is, that is what you have to remember, and anything else is false. It is measured in joules per kg. Yes, true. Gray is nothing but joules per kg only. Is measured in sieverts. No, it is measured in gray. It depends on the radiation weighing factor. No, it does not depend. It is the amount of energy deposited per unit mass to a medium. Yes, it is true. Effective dose is derived from absorbed dose multiplied by tissue weighing factor. No, it is equivalent dose into tissue weighing factor. Is measured in gray. No, it is measured in sievert. Takes into consideration the different radiosensitivity of tissues. True. Combines organ doses to give a whole body dose. Yes, it is true. In a dental film, it is in the order of 0.004 millisieverts. No, it is in some other order. I don't remember. Oh, no, this is true. In dental film, it is in the order of 0.004 millisieverts. Okay. So coming to the effects of radiation, either they can be somatic or they can be deterministic. Somatic takes place with if it is chance, it can happen or it cannot happen. It will happen only in the individual that is exposed. It does not go to the next generation. Whereas there are a few effects which will cause genetic defects or hereditary defects that will pass into the descendants. In them also, there is a chance for either deterministic effect or a stochastic effect. Both can happen. So if the dose is low, the percentage of incidence, if the dose is low, is that is deterministic. That is, it can happen. Skin erythema can happen, or there is only few effects that are there. Whereas in high doses, there will be chance for more effects, stochastic and deterministic effects, depending upon the dose and the threshold for each individual one. We'll just go through that. So deterministic effect, we are talking about cell death here. And there is a threshold below which there will be no effect. With increasing the dose, there will be increase in the effect also, that is the severity. So what are the deterministic effects? Skin erythema, infertility, cataract and fetal abnormalities are deterministic. These happen because of cell death. Skin erythema happens in 2 to 5 gray. Infertility can take place in 2 to 3 grays. Cataract in 5 grays. Fetal abnormality will happen if the exposure is there only in the 3rd to 8th week of pregnancy. So for the threshold for fetal abnormality, 100 to 500 milligray should be there. Lethality will happen if there is 3 to 5 gray. Hair loss will happen if 2 to 5 gray. Irradiation of the skin damage, irritation will happen in 20 to 40 gray. Skin doses in fluoroscopy are 50 milligray per minute. Tube leakage is 1 milligray per hour for 1 meter distance. These are some things which you have to remember. Yeah, they are asking these type of questions. So yes, not just the reasoning, but the numerical values for few of the things you have to remember. Next, stochastic effects happen only if there is cellular transformation. It is by chance. Even if there is increase in the dose, there might not be an effect, but the probability will increase. If you're increasing the dose, the probability of increasing the chances of having an effect will happen. And it is linear no threshold theory. So this is stochastic is where there will be mutations. So that is the place where we'll have cancers as well. That is the breast carcinoma and leukemia. So where we're talking about effective dose, we're talking about the stochastic effect. Okay. So equivalent dose, radiation protection. You need to identify equivalent dose with radiation protection, whereas effective dose we have to identify it with the cancer stochastic effects. Okay. So these are the direct tables that are given in FARS, which you need to remember. So what happens in pre-pregnancy and pregnancy? Whenever there is ovulation or fertilization, even if there is irradiation, then there will be no problem. Even post-conception 1 to 8 days, if there is irradiation, there are chances of fetal death. Whereas for the first trimester, in 2 to 8 weeks post-conception, there will be tissue abnormalities. From 9 to 12 weeks, there will be mental retardation, which is high in the 8 to 15 weeks and low risk in 16 to 25 weeks if there is more than 200 milligray of exposure. Whereas childhood cancers will happen from mid of first trimester to the end of 3rd trimester. There is significant uptake of radioiodine by fetal thyroid from 10 weeks. So for nuclear medicine, it is very important for us to avoid, because the fetal thyroid will take up the radioiodine and it will cause more effects for the fetus. Okay, so childhood cancers will take place from the half of first trimester to the 3rd trimester. Mental retardation, half of first trimester to 2nd trimester. How the questions are asked, we'll just see. The potential for the following fetal risks is maximum if radiation received in utero is at the following terms. Fetal abnormalities in 3rd to 8th week of pregnancy. Yes, true, we have just discussed. Mental retardation 8th to 15th week. Yes, true. Fetal death in the first trimester. No, it is just post-conception 10 days. After that, it is mental retardation and other abnormalities. Childhood cancers in 3rd trimester. Yes. It will happen in 2nd and 3rd trimester. So it is so this is false. Growth retardation will happen in 8th to 20th week of pregnancy. Yes, it is true. Deterministic effects of ionizing radiation include cataract, yes. Epilation, yes. Leukemia and lung cancer are stochastic effects because it is because of a mutation. Arrhythmia is a deterministic effect. Stochastic effects of radiation include infertility. No, infertility is a deterministic effect. Leukemia is a cancer, so it is stochastic effect. Cataract, it is a deterministic effect. Cancer, cancer is a stochastic effect, true. Hair loss is a deterministic effect, so it is false. Regarding deterministic effects, diarrhea and vomitings are example. Yes, diarrhea and vomiting are deterministic effects. There is a threshold dose above which they do not occur. Sorry, there is a threshold dose above which they occur. So this is false. Effects occur by chance. No, stochastic effects occur by chance. The threshold dose is the same for different deterministic effects. Yes. No, it is false. The threshold dose for different deterministic effects is different. So that is why we have this table where we are having skin erythema, it is 2 to 5. The threshold dose for irreversible skin damage, it is 20 to 40 gray. For hair loss, it is 2 to 5. For sterility, it is 2 to 3. For cataract, it is 5. For lethality, it is 3 to 5. For fetal abnormality, it is 0.1 to 0.5. Yeah. Severity increases with increasing dose. Yes, it is true. Regarding stochastic effects, the probability of a stochastic effect is independent of the dose. Is it true or false? Yes, it is linear, no threshold theory. So it is true. Occurs immediately after exposure to ionizing radiation? No, it can take decades. Stochastic effects can take decades, and it depends on so many things. It depends on if it is different for children, it is different for old age people, it is different for the type of cancer. Thyroid cancers will take too much time for the person to die, whereas pancreatic cancers will take immediately. The patient will have high mortality. Thyroid will have low mortality, and the cause and effect of stochastic effects is very variable, and it will take long time sometimes, and it will take less time for others. So it is false. Have a linear no threshold theory? True. Sterility is an example. No. Sterility is an deterministic effect. Breast cancer? Yes. All the cancers come under stochastic effects only. Regarding deterministic and stochastic effects, in the daily practice of diagnostic radiology, stochastic effects are commoner than deterministic effects. No, we have more skin erythema, cataracts, and all of this than cancers, right? So it is false. The chances of producing deterministic effects is the same for X-rays and gamma rays. Yes, it is true. No dose is considered safe for deterministic effects. No, below the threshold, it is safe. That is where we try to give the patients, that is the dose we try to give them, so that there will be no deterministic effects also. So it is false. Deterministic effects may be non-additive. It is true. Skin necrosis is an example of stochastic effect. No, skin necrosis is an example of deterministic effect. The threshold doses for following deterministic effects are typical. Cataract is 5 gray, hair loss is 2 to 5, arrhythmia is 2, sterility is 2 to 6, depression of hematopoiesis is greater than 0.5 gray. Yeah, these are all true. The potential risks to the fetus from radiation in utero include development of cancer, yes. Mental retardation, yes. Decrease in IQ, yes. Intrauterine growth retardation, yes. Leukemia, yes. So the risk factors for fatal cancers are specified, and it is for the fatal cancer, not for the incidence, whatever risk factors we're talking about, because incidence is variable with so many other variables as well. So for a uniform whole body irradiation, the risk of fatal cancer is 5% per sievert or 1 in 20,000 per millisieverts for the general population. So the risk is more for children, as we have discussed, than for the whole population. And the problem for quantifying this is the latency period, because irradiation happens at what point and the clinical manifestation is at the other point. Leukemias occurring in red bone marrow irradiated patients take a latency period of several years, and the peak incidence is 7 to 10 years. Whereas for solid tumors, it is 40 years. So there is a lot of variation and lot of, there's a lot of things that play a role in forming this fatal cancer. So it is difficult to say. So that is something which you have to remember and answer the questions. So regarding the effects of ionizing radiation, the risk of fatal cancer for uniform whole body radiation is 1 in 2 lakh per millisieverts. It is false. As we have discussed, it is 1 in 20,000. The risk of developing fatal childhood cancer from irradiation in utero is 1 in 50,000 it is 1 in 30,000 per milligray. The cornea is more radiosensitive than the lens. No lens is more radiosensitive than cornea. Radiation dose to the hands of staff arises from the use of radionuclides as well as from the X-rays. Yes, it is true. Deterministic effects are hereditary. No, stochastic effects are hereditary, as we have discussed. So this is the risk factors for radiation wake factor, the table as given. So from that table, we have already discussed. So we'll just go through them. High carcinogenic risk for radiation is for colon is one of it. Colon is there, and breast and bone marrow are high carcinogenic. That is high tissue weight factor will be there. The rest of them are false. Tissue weight factors are true for the following organs. Bone 0.05, no. Basically, you just have to see the high ones and the low ones. These type of questions, as far as I have answered in the current FRCR, they have not asked, but they're given in Oxford, so I have just put them. Just remember the high ones and the low ones and try to eliminate it. It is not possible to remember all of this anyway. So the risk factor, depending on the age of the irradiated person, it will keep decreasing. If the age at which they're exposed is less, they will have more chances of developing the cancer because they will live longer and they will develop the cancer. Then if the patient is irradiated at 60 to 70 years of age, they will have less chances of developing the cancer because they don't live that long. So that is the point of the graph. Total absorbed doses in diagnostic radiology for different examinations, that is the chest X-ray is the least of all. CT pelvis is the highest of all, and CT scan in general will have more than any of it, and fluoroscopy will also have more than other ones. So you have to remember chest PA 0.15 milligray, AP abdomen 5 milligray, lateral lumbar spine 12 milligray. Anyway, these are even important for the practical exam. So fluoroscopy skin rate is 5 to 50 milligray per minute. For CT pelvis, it is 10 to 30 milligray. So the following entrance surface doses are typical for the following examination. PA chest film 0.15 milligray, true. Lateral lumbar spine 12 milligray, true. AP skull X-ray is 2 milligray, it's true. AP abdomen film is 8 milligray, no. AP abdomen, it is 5 milligray. Fluoroscopy dose rate is 100 to 150 milligray. No. Fluoroscopy, it is 5 to 50 only. Okay. The effective doses are typical for the following examination. CT head 2 millisieverts. It's true. It is important to remember that. For PA chest film is 0.15 milligray. It is false, as we have just discussed. CT chest is 4 milligray. Millisievert. False. Barium enema is 7 millisieverts. It is true. Lumbar spine 0.8 millisieverts. It's true. So the risk of developing fatal childhood cancer is 3%, that is 1 in 33,000 per milligram, as we have discussed. So how are we going to categorize the dose? From where all are we getting this radiation? There are 4 natural categories from which we are getting the radiation. One is the cosmic radiation, that is from the space and from the atmosphere and all of that. At sea level, it is almost 320 micro sieverts per year. And there is terrestrial exposure, that is gamma rays are emitted from radioactive materials in the Earth's crust, and all that and all is 350 microsieverts per year. The major part, that is 60% of whatever we are getting, is the internal source, that is whichever we are having in the food, that is potassium 40, that amounts for 270. And there is radon, which is produced because of the decay from uranium, and its atomic number is 82. Above 82, whatever atomic number, whatever elements are there, all of those are radioactive and they decay and they give alpha particles. So these are the things you have to remember. So International Commission on Radiological Protection, that is ICRP, has given these 3 principles in order to understand how much energy are we depositing in the patients and in the surrounding one. To stop that, they have given these 3 rules, that is you need to have justify, you need to optimize, and there should be a system of dose of limits through which we will decide how much the patient is getting, how much the technician is getting. So all of this radiation protection is all for the we're talking for the technician and the patients. Okay, so what is justification? Justification is if there is benefit more than the risk of what we are doing, it is we are justifying that this is very essential for the patient to get it done. We have to do this examination because the patient is not having a proper diagnosis, and it depends on his life and death issue. Okay, so there should be benefit more than the risk that the patient is getting. So the risk depends upon how much dose are we giving, and the risk will increase with if it is a child that is we are exposing, because the children will have more stochastic effects than the older people. And if the patient is pregnant, we need to weigh the benefit and risk factors and then only give the radiation. Next, optimization. The principle of optimization is nothing but if you are using ionizing radiation, the dose should be as low as reasonably achievable, and depending on the economic and the social factors as well. So if there is something like ultrasound is easy for you, if ultrasound is something which will give the diagnosis, you don't have to go for CT. If there is CT and MRI, but the economic factor, CT is cheaper than MRI, and it is having enough benefits than risk, then you'll go for CT than MRI. So all of these things you have to you need to calculate and then give the radiation and select the correct examination that is important for the patient. As low as reasonably practicable is ALARP principle. It is optimization is built in number of levels, like it is incorporated in the design of the equipment to control the X-ray output during fluoroscopy, and even during the selection of the procedure. What kind of procedure are we doing? So we use the lowest possible dose, that is we adjust the kV in radiography and all. The operator uses particular techniques, so minimum screening times, low dose CTs and all of those. And quality assurance programs are also in place to ensure this equipment performance, so that the patient will receive only as low as reasonably practicable radiation. So next, coming to dose limitation. Doses in excess of those values are deemed not to be justified, no matter how great the benefit. So dose limitation is for the patients. This is this is very important. So dose limiting, we are limiting to whoever is. We cannot apply the same limit for the technician and the public, because the technician is getting benefit in the form of a job, monetary benefits and all. So they will have a little higher than the public. So we'll discuss all of that in the next class. So that is what they mean here, that the radiation is different for the technician, whoever is working, and the members of the public. Dose limits do not apply to patients. The control of the patient dose is based solely on the principles of justification and optimization. they include limits on effective dose to restrict the risk of stochastic effects, because as we have discussed, an equivalent dose is for radiation protection. Stochastic effects, effective dose is for stochastic effects. Risk increases with time and reaches a maximum value of somewhere 20 years after the period of employment. So these are all the things that we have to discuss. So for effective dose for employee is 20, whereas for public it is 1 millisievert. This is very, very important. These are the, actually it is given in fast like this, but the new guidelines have said that length of the eye, it is 20 millisieverts for employees and 15 for public. Skin, hands, forearms, feet, ankles, it is 150 millisieverts for employees and 50 for public. And for abdomen of a woman in reproductive capacity, it is 13 over a period of 3 months. And for the fetus of the pregnant employee, it is 1. For public, we don't generally use radiation for unless it is a very like a serious problem for the pregnant woman. So there is no guidelines given. But for employee, it is 13 over a period of 3 months. This is very important. Okay. So this is overall what we have discussed today, and as a complete learning points. There's a lot more to radiation protection that we need to cover. We'll do it in the next class. I hope you enjoyed the class. Thank you.